name is Dr. Thomas Heil, and I am an interventional pain physician practicing with Southeast Pain Care. I've been here for almost a full 15 years now, and like all the physicians at Southeast Pain, I am double board certified. I was trained in anesthesia and interventional pain management in Pittsburgh, and I'm board certified through the American Society of Anesthesiology in both. All of the physicians actually in our practice are both board certified and fellowship trained through ACGME accredited programs. And that's very important for any physician that is referring to any sort of practice, because you want your patients to be treated by physicians who have met, at very least, the minimum qualifications that are set throughout the nation. And not every pain physician in the region is fellowship trained and ACGME accredited. Southeast Pain Care is not a classic multidisciplinary practice in that we don't necessarily employ every discipline, including psychiatry or psychology, but we do refer to psychologists all the time. We work with physical therapists, and we practice a very broad range of pain management options for patients, including medical management where necessary, the prescription of opioids under fairly strict guidelines, and we do a host of interventional procedures as well, ranging from routine epidural steroid injections and nerve blocks to the more advanced procedures that include radiofrequency lesioning and even implantable devices like spinal cord stimulation. So if you've gotten to the point where someone has pain that is not responding to the simple measures, and you've written 1 or 2 prescriptions for hydrocodone or Percocet and the pain persists, that's the time to get your patients to a pain specialist. And in many cases, we have some advanced interventional options that you may not have even known were available that can either reduce the amount of narcotics that patients have to be exposed to or may eliminate them entirely. And spinal cord stimulation is one of those. Spinal cord stimulation is a really exciting method for managing pain, but it only treats nerve pain. Anything that is neuropathic actually will respond, for the most part, to this therapy, and that includes the majority of what we do, which is failed back surgery syndrome and radiculopathies, but other things that you may not have thought of, for instance, peripheral neuropathy from diabetes, idiopathic neuropathies, postherpetic neuralgia, just to name a few, complex regional pain syndrome, and there are even physicians in the region that are using stimulation for managing intractable headaches. So anything that is neuropathic is likely to respond to spinal cord stimulation. Conversely, anything that is not neuropathic, like arthritis, disc pain, muscle pain, will not be treated by spinal cord stimulation. Spinal cord stimulation works from the inside of the body out. The spinal wires are placed directly on the dura in the spinal canal in the central nervous system, and there is no medication that's being injected. So the patients are not getting numb, they're not losing feeling, they're not losing strength as they do with labor epidurals. What they are doing is getting electrical interference and adjustment of the neurohumoral mechanisms in their spinal fluid to reduce pain signals. So there's no loss of function, and in fact, the idea is to improve function. And what stimulation does is replaces that terrible, painful feeling with any of a broad range of sensations that patients describe. The ones in the past who have told me that they really like the way the system feels tell me that when they turn it on, it's almost as if they've turned on an inflatable suit, and there's warm air circulating all around their body, replacing the feeling of pain with warm circulation. More recently, with the advances in the stimulation platforms and the programming that's possible, often patients will describe a sensation of sitting in a bathtub full of Alka-Seltzer with a warm, fizzy, bubbly feel throughout their body. What's really most interesting is that patients don't even go forward with having the stimulator implanted permanently unless they absolutely know for certain themselves that it's going to work. And the way they know is that we do a trial first. The trial is done under local anesthesia in the office. There is no sedation required. It's a fairly painless procedure. We use a lot of local anesthetic or numbing medicine to make sure that the patients don't feel the small needle stick that's necessary to insert the catheter. But the procedure itself takes anywhere from 15 to 20 minutes, and the permanent implant is done surgically, but under local anesthesia with sedation. It's an outpatient procedure that takes approximately an hour to an hour and a half. The patients go home the same day. Usually there's a little bit of post-op discomfort for approximately a week, but for the most part, patients are back to a fairly normal level of function within a week to two. What we want to do with spinal cord stimulation trials is, of course, achieve pain relief for patients. There's a wide range of what patients and physicians consider success with spinal cord stimulation. I've been doing this now for about 15 years, and most insurance companies require the patients to feel that they have about 50% pain reduction during the trial before they'll pay for a permanent implant. And what that tells us is that only about 50% of the pain that that patient is suffering from is neuropathic, and the rest of it may be coming from arthritis or musculoskeletal causes that, again, will not be treated over time with stimulation. Coming up with a percentage reduction of how much pain relief the patient is getting is often challenging. It's not something that is 100% objective, of course, and what I may feel is unacceptable pain relief at 50%, the patient who's suffering from it may say, look, I don't care if 50% is all I can get rid of. If I can start cutting back on some of my medications as a result of this, and if I can get half of my pain to go away with a stimulator, I'll gladly take it. So the 50% cutoff is sort of a good rule of thumb, but again, the patients who do well with these stimulator systems say during the trial, it changes their lives. There are three important components of having spinal cord stimulation be effective over time. First is we have to get the stimulating catheters in the right location. Second is we have to hit the sweet spot of stimulation. And the third is we have to keep that stimulation in that sweet spot over time. And by over time, I mean not just days or weeks, but years, because these devices are implanted with the intention of the intraspinal component not being adjusted or moved, or even replaced ever if necessary. So we have a rough idea where the stimulating catheters need to go. But each individual patient has a specific sweet spot in their spinal canal where if we stimulate that area, it's like swinging a golf club and hitting the sweet spot on the club. So in order to hit that sweet spot, there are several things that are going to make that possible. One is, of course, getting the catheters in the right location. But the second is getting enough stimulating contacts in the region of that sweet spot so that we can steer the current around where it needs to be placed more specifically once we get the general target. And the third is being able to constantly control where that current is going. Boston Scientific is the only company that has what is called multiple independent current controls. And what that means is that they can take the electrical stimulation in 1% increments over a wide range of these catheter locations and contact locations and steer that current within 1% around a certain region where the catheters are placed. They also have developed a system that allows for 32 contacts in the spinal cord region with just one battery. So we now can not only program three-dimensionally, but we can program three-dimensionally around twice as many contacts, taking into account the CSF thickness, the catheter location east and west mediolaterally, and north-south or rostrocaudally, and use the software that has been developed within the stimulation system to focus the current directly where that sweet spot is on the patient's spinal canal to cover nerve. In most instances, we don't ever have to touch the catheters that are in the spine again. All we have to do is replace the batteries themselves, which is a 15 to 20 minute procedure. We make an incision where the old battery was under the skin, take that out, plug a new one in, and that's the end of it. So the long-term maintenance for these is very, very minimal once we get stimulation where we need it. So placing the stimulator catheter both for the trial and the permanent stage, again, is a very simple procedure. And it's also very safe. The two greatest complications are either lead migration, meaning movement of the leads in the spinal canal out of place to the point that you simply can't re-stimulate, or infection. The incidence of infection in a spinal cord stimulator implant is certainly less than 1%. Lead migration has actually been quite a challenge over years because once these catheters are in the spine, we stitch them in place and in fact anchor them to the interspinous ligaments surgically when replacing the permanent device. For the most part, we can reprogram these systems to cover that now and make up for the difference so that if the lead does happen to move north-south or east-west to a certain amount, we can recapture stimulation with the new software that's available. So that was a lot of information, and some of it probably is a little bit confusing. So let's boil it down to really the important parts. Most important is don't focus necessarily on a specific diagnosis in your patients. Very few primary care physician patients have just diabetic neuropathy, post-herpetic neuralgia, or RST. They've got a whole bunch of conditions, some of which may and some of which may not respond to medical or interventional therapies. What you need to focus on is the type of pain. So whether it is burning or throbbing or lancinating, anything that seems like it may be neuropathic, don't worry about the diagnosis. Send it to us and let us at least explore what options we have for